Dear students, let us start with the ENT segment. The first MCQ I have given, which of the following wave on ABR, that is your auditory brainstem response, is most sensitive. Very new, fresh MCQ for your upcoming examination. So let us learn a few important points related with the BARA, brainstem, evoke response audiometry, also known as ABR. Just one second, ABR, auditory brainstem response. We have several waves with a simple mnemonic which we always mug up. Wave 1, wave 2 is for aetna, wave 3 is for cochlear, wave 4 is for olivary, wave 5 for lateral lemniscus, wave 6 and 7 is for inferior collicular. Am I understandable? Now, out of these, why this investigation is important? For your central institute, for your NEET examination, just remember one thing. One is an investigation of choice for neural deafness. Investigation of choice for neural deafness. It can be used as screening procedure of choice in high risk baby. So it is used in screening risk of high risk babies. We use as a screening procedure of choice. So now question is, which investigation is normally used as screening procedure of choice? That is autoacoustic emission by outer hair cells. Am I understandable? But in high-risk baby, we use BARA. Therefore, this is one of the important crucial investigation in ENT as well as pediatrics. Which is the largest wave? First MCQ. Lateral lemniscus. Lateral lemniscus. Fifth is the largest wave. But the MCQ which I have asked you, which is most sensitive? So always remember the wave 1. The wave 1 is the most sensitive now among these seven waves. Clear? So BARA, the wave 1 is the most sensitive. Now your NEET people can even ask you what you do for the higher cortical centers. So just remember one drawback of BARA. These waves can diagnose the retrocochlear compartment, neural compartment, except medial geniculate body and auditory cortex. And what we do for medial geniculate body and auditory cortex, always remember, we do cortical evoke response audiometry SERA. Clear? So I will just brush up all the basic investigation for conductive deafness. Just remember impedance audiometry, that is tympanometry with stapedial flux. For sensory, like menials, presbycusis, we use electrocochleography, and for the neural we use BARA. For the higher centers we use SERA, cortical evoke response audiometry. Clear? Coming to the next one, very favorite question of your examiner is your which transmission of otosclerosis, genetic transmission, is an autosomal dominant condition. Always remember, is an autosomal dominance. Am I understand? Autosomal dominant condition. Which viral infection related with, which infection may be related with autosclerosis? Just remember 3 MCQs, my favorite questions. Autosclerosis related with which infection? Is here measles. Is here measles. Sensory neural deafness is related with mumps. And if the examiner asks you about congenital deafness, most common infection related with the congenital deafness, so it will be cytomegalovirus. C for congenital, C for CME. These are 3 important points. Now on autosclerosis, which is again a favorite topic of your examiner, I will be giving you 6-7 points which are worth remembering. One is autosomal dominant, we have already learned. The incidence is more common in female than male, but in our country, India, it is more common in male. Pregnancy is one of the predisposing factor. Any ENT MCQ pregnancy word, go for autosclerosis. Is a conductive deafness, which is a hallmark feature, a heart notch, which is seen in bone conduction at 2000 Hz. These are worth remembering. Drug of choice, always remember sodium fluoride. Surgery of choice, stepidotomy, not stapedectomy. Double ring sign, like I have updated in the DVT, double ring sign, or cookie bite audiogram. Cookie bite audiogram, these are the feature of cochlear autosclerosis. But most common site is your area anterior to oval window, that is fistulae antifenestra. Fistulae antifenestra. This is what is required in the last minute revision of autosclerosis. Clear? I will be trying my best. I'll be using this platform to just teach you what to do in the last minute revision of these topics. Clear? The retracted tympanic membrane adherent to promontory is described as, is again one of the important points on retraction of the tympanic membrane. Why it is important? Because it is one of the most common cause of any pathology in middle ear. Because of eustachian tube dysfunction, you get retraction of the tympanic membrane. Now I have 2 parts of the tympanic membrane. One is par flaccida, one is partenza. So just remember an important point. T for TOS classification. T for TOS classification, but it is not for tensa. Just remember this one. For flaccida, we use TOS classification, and for tensa, we use Sethi classification. These are the two important ones. Then I give a simple mnemonic to my students. FMT, par flaccida, we use TOS classification, but we use reference point. What is the reference point? Reference point is my malleus, because malleus is a higher level, is at the level of par flaccida. So if this is my par flaccida, this is my partensa, this is malleus incus stipes, your basic anatomy on your tips. Now, I can use my TOS classification. I can divide into 4 types. The one, par flaccida, retracted, but not touching malleus. Grade 2, touching malleus. Grade 3, touching malleus, but there is a mild damage to epitympanic. And grade 4, severe damage. So can I write for you, all the students who are listening for the first time? So grade 1, grade 2, these two important classification for your online examination. Grade 1, par flaccida, retracted, but not touching malleus, Grade 2 is touching malleus. Grade 3, there is a mild damage in epitympanum. Grade 4, there is a severe damage in epitympanum. That's it. Now, coming on next classification, SIT, S for Sethi classification, I for incus, T for tensa. I divide into 4 types. Grade 1, 2, 3, 4. Grade 1, obviously, not touching incus. Grade 2, touching incus. Grade 2, touching incus. Now, what is the difference between grade 3 and grade 4? Grade 3, it is touching promontory, but it is mobile. And grade 4, it is adherent to promontory. So the question I have given you, the tympanic membrane is adherent to promontory. So it go in the favor of grade 4. Now listen carefully. In examination hall, sometimes we are just under such a mental pressure. Grade 4 means last grade. I attempt the D option. This error should not be there. Examiner is deliberately giving your 4th option as a C. So just remember, 4 doesn't mean the last one. Always be alert in the examination hall. Am I understandable? Are you getting this point? So we are using Sethi classification, and this will be grade 4 Sethi classification, tympanic membrane adherent to promontory. Coming to the next one, very favorite topic, bone anchored hearing aid. I tried my best to, in these 10 MCQs, I am giving you 10 important topics which should be on your tips. All of the following are true about bone anchored hearing aid. So first of all, just build up the concept. Hearing aid is for conductive deafness. This conceptual learning should be there. It should be conductive deafness. Conductive means air conduction. Air conduction means external auditory canal. So I use my all hearing aid in the external auditory canal. But listen carefully. In which scenario, in which case, we will be taking the help of bone conduction? In that scenario, in which air conduction, external auditory canal is not viable. It is not possible to keep the hearing aid in the external auditory canal, which is a condition. You tell me, what are the indications? There can be pus in the external auditory canal where I will be keeping the receiver. If there is external auditory canal atresia or canal stenosis, so which are the 3 important indications? Canal atresia, canal stenosis, pus in the canal, or any contraindication of using conventional hearing aid. We use bone anchored hearing aid. One of the potential questions, even I have covered in DVT, most common important complication, that is your skin reaction. Skin reaction is one of the important complication of bone anchored hearing aid. So what I am asking you, all are true except, it means I am asking you false statement. It is surgically implanted titanium fixture. Absolutely, because of this titanium we have allergic reaction on the skin. It transmits sound directly to the cochlea via bone conduction using the principle of osseointegration. Just wasting your time in the choice. Is it true? Option is a mechanism. It is indicated in a patient with a chronic discharging ear. Absolutely. If there is a pus in the canal, we can't use hearing. It is not useful in unilateral severe sensory hearing loss. We can use even in severe sensory hearing loss if we use high power. Am I understanding? So this will be a false statement. D option is a false statement, therefore is the right answer in this MCQ. Clear? Bone anchored hearing aid, one of the important topic, cochlear implant, brainstem implant. Always remember, conductive deafness, we prefer hearing aid. But even in few sensory neural cases where there is a contraindication of using cochlear implant or brainstem implant, I can still go for high power hearing aid like infants, pediatric age group, and old age, rest by cases. So in extremity of ages, we prefer hearing aids first one. Second, the examiner can ask you, in pediatric population, which hearing aid is best one? Just remember BTE, behind the ear, is one of the preferred hearing aid in old age as well as pediatric population. Clear? So these are the important points which you should be aware of. Coming to the next one. All of the following are true regarding benign paroxysmal. I want everybody listening to my session, just remember, be aggressive in the All India examination. Try your best to attempt all the MCQs. It will be only possible when every topic will be on your tips. All of the following are true regarding benign paroxysmal position, whatever. But just try to learn this one. BPPV. Just close your eyes. 4 points should be on your tips. Posterior canal is involved. It is calcium carbonate loose foreign bodies. Hall-Picks maneuver is your basic investigation. And Appley's maneuver is your treatment. That is a 4 point should be on your tips. Again, posterior wall, loose calcium carbonate body, Hall-Pick and Appley's. These are the 4 points. Am I understandable how the toppers, the rank in top 500, how will be possible when you see BPV? These 4 points should strike your mind. No need of reading every line. Just have a look on the whole 4 choices. Bird eye view, what we use, eagle's view. Just see each and every word. You will see lateral semicircular. Now, what is the approach to attempt this MCQ? Beta, all those students who are planning or targeting top 1000, 2000 rank, I always say, try your best to get a rank within 2000. Never build up the pressure of top 10 or top 5. Forget it. Top 2000, I will get my dream branch. If you want in top 1000, 2000, just remember 1 point, beta, bird eye view we have to do in your examination because we don't have ample time. PPV, lateral is visible. Once you see lateral, just confirm he is asking true or false. He is asking all are true except means false. That is definitely this option. Remember, what is the eagle's view of attempting MCQ? Benign paroxysmal position. What I go topic. Aate hi beta aapke mind mein click karna chahiye, should be posterior, and you see it is lateral. Just go. Don't read the remaining choices, beta. I promise you, you will get top rank because you will get ample time to crack difficult MCQs. But even if you want to read, now we can confirm the remaining choices. Simon's maneuver is done to treat this condition. Yes, Appley's. If you listen to my old previous your GT discussion, I have explained all the exercises we advise in BPV. Appley's is one of the best. Then Simon's maneuver, one is Foster's maneuver we are using, but Appley's is one of the choice, position exercise of choice. There is no hearing loss in the condition. The word itself is telling you it is what I go. So nothing to do with hearing aid. Why? Your basic concepts clear. Cochlea, hearing, vestibule, balance. That's it. Calcium carbonate are involved. Absolutely true. So it means B is the right answer. That means false statement. Clear. Coming to the next one. A patient of head injury and bluish discoloration. Just expect these clinical oriented MCQs. Over the mastoid, bleeding from the external auditory canal. There is complaining of hearing loss with normal facial nerve function. After 3 days, patient has facial weakness. What is the possible diagnosis? Now, what is the history? The history is of bluish discoloration over the mastoid, battle sign, bleeding from the external auditory canal. It means there is some trauma to external ear mastoid. And if you are master of the basic skull fracture, temporal bone fracture, we divide it into longitudinal, temporal, longitudinal, and your transverse. So just remember, if the fracture, if the temporal bone fracture, the damage your parietal bone, squamous bone, this area we call it as longitudinal. It damage your external ear, middle ear. You will be having bleeding in the external auditory canal, traumatic perforation, ossicular injury. All these go in the favor of longitudinal fracture of the temporal bone. Am I understandable? In occipital transverse fracture, it will be sensory neural deafness. But in this case, in longitudinal, always we have conductive deafness. Coming to the next one, in a patient of epiglottitis, very important topic, either in ENT or pediatrics, question waiting for you. Patient of epiglottitis, all of the following are true except, again, he is asking false statement. Now listen carefully. what the examiner is doing. Epiglottitis. Once the topic of epiglottitis comes, just have 4 points in your mind. Streptococci, not H influenza. Thumb sign positive on the lateral view. T for thumb, T for toxic patient, is very toxic patient. And the 4th point, never ever give any painful stimulus. These are the 4 areas on which any examiner make the MCQ. So in a patient of epiglottitis, all of the following are the part of management except intubation, absolutely. Dyspneic patient. Steroid to reduce edema, absolutely. First line of drug we are using. Antibiotics to control infection, absolutely. We'll go for IV antibiotics. Streptococci, because is a emergency, is a toxic patient. Repeat direct laryngoscopy every hour, not at all. Is it traumatic? Take my word, the child, the patient will cry. Once he will cry, the dyspnea will precipitate. Never ever give any painful stimuli. So repeat direct laryngoscopy. 2-3 years back in AIIMS, they have asked the same question. The choice was per rectal temperature monitoring. So per rectal temperature monitoring, such type of things we will never do in a patient of epiglottitis, because any painful stimuli can precipitate the dyspnea. So just remember, epiglottitis, streptococci, toxic, IV antibiotics, never give painful stimulus. This is the way we have to approach in the last session. This is the future I'm showing you. This in upcoming years, they will be asking these questions. They have combined surgery, ENT, pediatrics. 6-year-old boy brought to the hospital at 8 p.m. He told his parent that he swallowed something, but he is not confident. He is not in distress, no distress, nothing. On X-ray, chest X-ray shown to you. Now on X-ray, what we are having a round foreign body. Something is there. Something is there. The child is not giving any history, but on X-ray we are getting something. So the patient, there is currently a patient laparotomy. The examiner is trying to waste your time in emergency operating room. That will take minimum 4 hours to complete. What will be the next step in the management? Now just take, if this foreign body is round foreign body, the edges appears to be round, it means it can be, there is a possibility, remote possibility. If I see this X-ray, I can say it can be a button battery. Am I understandable? So just considering the shape on the X-ray, I will advise we should take an emergency. We should take it as an emergency, and we should remove as soon as possible. As soon as possible. Why? Because button batteries, they release chemical and cause necrosis of the surrounding areas. Most dangerous foreign body, even in external auditory canal, they can lead to facial palsy. So what we will do, we will remove it as soon as possible. Now let us read the choices. Operate after 4 hours. I will not advise to wait for 4 hours. Second, operating room need to be open and operation should be performed regardless of the fasting time. Absolutely true statement. Conservative management, not at all. Advise HRCT to locate the actual patient. No. Because this foreign body appears to be round, there is a possibility of button battery, so it is better to remove it as soon as possible. Clear? Nice MCQ expected in the upcoming examination. Clear? Coming on the next one. Which tracheostomy I'm showing you? One of the simplest MCQ of this paper. I'm showing you a cortex tracheostomy, but there is fenestrated. There are opening. What is the role of this fenestration? Anybody? Just common sense, common sense. Whenever the patient will keep a thumb on the opening, the ear will move and will help in the voice of the patient. So always remember, we have 3 types of tube: cuff tube, uncuffed tube, fenestrated tube. Cuff tube, normally we use. But a drawback, pressure necrosis. They can ask you how frequently we deflate the cuff. Every 2 hours for 5 minutes. Every 2 hourly for 5 minutes. But which tracheostomy tube is best for voice is ear fenestrated tube. And this same concept we use in Blom-Singer tracheoesophageal prosthesis. Am I understandable? So even in the Blom-Singer tracheoesophageal prosthesis, all the tracheoesophageal prosthesis, we are using this concept. We make an opening via which the air flow and create a sound for the patient. So this answer will be voice. Coming to the next one, surgical demarcation between level 3 and level 4. This is one of the MCQ in the recent Central Institute. This can be in your NEET examination at any point of time. Just remember all the levels. 1A submental, 1B submandibular, and this is my jugular chain, which we divide into level 2, 3, 4. Upper jugular, middle jugular, lower jugular. Level 5 is your posterior triangle. Level 6 and 7 are the pretracheal. Am I understandable? In front of the midline. Now, I am showing you this diagram on which you can clearly demark level 3 and level 4. Always remember, hyoid bone divide level 2 and 3, while the cricoid divide level 3 and 4. So the right answer will be horizontal line along the inferior border of cricoid cartilage. Clear? I tried my best to give you all the best possible topic in this CBT. Just try to learn